Hello, and welcome to the Alabama Public Health Training Network. Disasters, whether natural, man-made, or technological, all have the potential to affect our psychological health. Post-traumatic stress disorder, commonly known as PTSD, is a mental health condition that can be triggered by experiencing or seeing a traumatic event. People experience PTSD as a result of different types of public health emergencies and all hazardous disasters. Some of these public health emergencies include pandemic influenza, infectious and communicable disease outbreaks. PTSD also occurs as a result of the devastation and aftermath of all hazardous events, including floods, hurricanes, fires, earthquakes, tornadoes, and winter storms. We want to also consider the impact of terrorist attacks, including explosives, active shooter incidents, toxic threats, and military combat, all of which have had an impact on the nation, the state, the local community, friends and family, and most importantly, our active military service workers and retired veterans. Today, we will provide an overview of PTSD and discuss the signs, symptoms, intervention strategies, and treatment options that are available to people who have been impacted by PTSD. Thank you for joining us today for our program, Post-Traumatic Stress Disorder Following Public Health Emergencies and All Hazardous Disasters. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation forms are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation form. While content may continue to be relevant, CE credit will only be awarded for 2 years for social workers, expiring on June 30th, 2017. My name is Elena Parker Merriweather. I'm the Minority Special Populations Coordinator for the Center for Emergency Preparedness. Joining me today is Dr. Tara Langston, licensed clinical psychologist, and Mrs. Jennifer Clark, life and wellness coach, who will share some insight regarding her journey and survival through PTSD. Welcome. Dr. Langston, tell us a little bit more about PTSD.
You want me to start on my... Okay, perfect. So before we start talking about PTSD specifically, one of the first things we want to look at is how do we define trauma? And I'm sorry, I honestly don't know which way I'm supposed to be. All right, perfect. And we really need to do this in order to make sure that everybody's talking about the right thing, or the same thing, not the right thing. So we really needed to operationalize the definition, and this makes the research be more applicable, be more generalized to everyone. And I think it also kind of pays respect to the fact that these experiences are more serious than, and have more impact on somebody than another experience may be. And, you know, the word trauma can kind of infiltrate into everyday language, and people say, oh, it was traumatic when I don't know, broke my arm or something like that, when it doesn't meet, like, clinically what we're talking about, if that makes sense. So trauma was first included in the third edition of our diagnostic manual, and it was defined as a catastrophic stressor that was outside the range of usual human experience. And unfortunately, we realized that these experiences weren't that atypical. This definition also received a lot of criticism because it was very vague and difficult to interpret. So the DSM-IV became more explicit and required that somebody have experienced or witnessed an event that involved actual or threatened death or injury. However, it required the subjective component of them responding to the event with helplessness, horror, or intense fear. And what we've learned is that that really had no clinical utility, and also it would be sometimes the one factor that would prevent somebody from being diagnosed with PTSD. So it's been eliminated. So this slide should actually say DSM-V because that's what we're on now, and I apologize for that. But currently, how we think of trauma is its exposure to actual or threatened death, serious injury, and then sexual violence has specifically been included in the definition. So somebody can experience this event directly or see somebody else experience it. You can learn that a close family member or friend has experienced the event. Also, having repeated or extreme exposure to adversive details of a trauma. So this includes, first responders and police officers. And the examples that they give, first responders often have to collect human remains. Police officers are repeatedly exposed to the kind of graphic details of child abuse. This exposure does not include media exposure, television exposure, or movies unless it is a component of your job. So somebody who works with the police and child pornography, they're going to be exposed to a lot of kind of graphic abuse details that they can't necessarily turn off, that type of thing. So after somebody experiences a traumatic event, often one of the first things that they say is that they just feel relief to be alive. This may be followed by stress, fear, or anger. They may find that they're unable to stop thinking about what happened. So many survivors show a very heightened level of arousal, and it can cause them to react strongly to sights, sounds, and even smells around them. Sometimes the smells or the sounds will trigger memories of the event itself. These stress reactions can last for several days or even a few weeks, and often what we find is that they typically decrease over time. Some specific reactions to traumas include feelings of hopelessness, trouble concentrating, feeling on guard, being easily startled, feeling withdrawn from others, detached, irritability or anger. People can have trouble at work and at school. And moving on. It's important to remember, though, that for most people experiencing a trauma, that they're going to recover without their symptoms progressing to PTSD. So we don't want to equate necessarily trauma automatically equals PTSD. We also know that people can experience a trauma and develop PTSD and still recover from it. Another thing to keep in mind is people are significantly affected by several bad events that don't meet the definition of what we consider a trauma. We do know that PTSD can affect anyone regardless of their age, gender, ethnicity, or really any other social demographic, but we have found that certain populations appear to be more vulnerable. These include people who have a trauma history, people who endure a longer lasting trauma, so ongoing child abuse, physical or sexual, military members during deployment settings. Kids and adolescents and females tend to be more vulnerable populations. Exposure to domestic violence in the home puts somebody at increased risk for PTSD. Having a pre-existing psychological disorder or being diagnosed with acute stress disorder, which we'll talk about in a minute, following a trauma is also going to put somebody at an increased risk. First responders have an increased risk, as we spoke briefly to a second ago, and somebody with a limited support system. Righty, so looking at some factors that place first responders at increased risk, there's just some aspects that are inherent in their job. They often suffer from chronic fatigue levels. They have cumulative stress because of repeated exposure to trauma. They're exposed to mass violence and destruction. They have prolonged rescue operations that sometimes fail. They're exposed to human remains and dismembered body parts, and sometimes those include their fellow responders. They see coworkers or even their partner killed or injured in the line of duty. They witness, mass death often, including death of children. So right after a trauma, as we mentioned, almost every survivor will find himself or herself unable to stop thinking about what happened. Stress reactions such as increased fear, nervousness, jumpiness, upsetting memories, efforts to avoid reminders of the trauma typically decrease gradually over time, but sometimes they don't. And we want to make sure that anyone who is having symptoms from their trauma that are impairing their daily functioning, whether it be their work or school, interactions with family and friends, or just kind of day-to-day living, somebody who is using increased alcohol or other substances to cope with their symptoms, and obviously anyone who has any thought of hurting themselves or others, regardless of how fleeting the thought may be, we want them to ask for help. So there is not one cookie-cutter clinical presentation for PTSD. There are some symptoms that are considered to be hallmarks, though. Trauma-related nightmares being one of the most commonly reported and distressing and impairing symptoms. And these nightmares differ significantly from, idiopathic nightmares. They're not, because actually what they really are considered is flashbacks. And it kind of makes sense when, during the day you can distract yourself from intrusive thoughts, but then at night your conscious awareness, is suppressed and the memory floods back in. And so they often find themselves waking up in the middle of a flashback or a trauma-related nightmare, and they have the physiological arousal that they would have during a flashback. So or during the trauma, because it feels exactly like the trauma is happening again. And as you can imagine, this really disrupts somebody's sleep, because who wants to go back to sleep, even if you can after being that aroused, you don't want to go back to sleep and risk having the dream reoccur. Hypervigilance, or that being on guard, avoidance behaviors, numbness, and anger are also very common presentations.
Do these presentations vary across the lifespan if you're dealing with children, young adults, or
yes,
older adults?
Yes, and we'll talk briefly, or we'll talk about the specific diagnostic criteria, but to go ahead and answer that, children often express their trauma symptoms differently. So they will have, they'll engage in play that has traumatic themes to it. Often they can't tell you the content of a trauma-related nightmare. So I think you could tell from their distress, and we would assume if a child wasn't having nightmares before and was having one after, that they were likely, and that's not really a requirement. One of the things that happens, people have PTSD, and depending on how long they've had it, their presentation is definitely going to be different, because the behaviors, particularly the avoidance behavior, is very adaptive in the beginning, especially if I go to this place and it reminds me of my trauma and I have all of my symptoms, well, I cannot go to this place and then I feel better. Unfortunately, what we find is that their world starts shrinking because they have to avoid more people, more things, because as PTSD progresses for a lot of people without getting intervention, their symptoms are just going to continue to escalate. And so you have maybe somebody who is in Vietnam who hasn't hardly left their house for, decades at this point. Okay. Alrighty, so we just recently shifted to our new diagnostic manual, and it's still an ongoing process for some people. There was a lot of hesitancy for some, but if you're a provider, you can still see people who were diagnosed under the old criteria, and obviously we would be diagnosing somebody with the new criteria now, but there are some changes that we're going to talk about, I think, that are bear mentioning. One of the most noticeable changes is that a new diagnostic category was created for PTSD. And so it was subsumed under the anxiety disorder category, and it's now in a category titled trauma and stressor-related disorders. As we talked about earlier, the diagnostic criteria for what constitutes a trauma has changed. In addition to this one being more explicit, it also has eliminated that subjective reaction. So the four clusters, there are now four clusters of symptoms. There was hypervigilance, avoidance, and intrusive thoughts. The avoidance has been separated out into two clusters, avoidance and persistent negative alterations in cognitions and mood. Okay, that's a mouthful, that one. And this really, I think, just came more from our ongoing understanding of PTSD. And so the thoughts that people have definitely have occurred after the trauma, and all of the symptoms can kind of cycle off of each other, if that makes sense. The specifiers have changed, so we have dropped acute versus chronic PTSD, and we'll talk about the specifiers for DSM-V in just a second. Also, completely separate diagnostic criteria has been added for children 6 and under. Okay, forget these are on 2 slides now. So we've discussed, looking at DSM-V, we've talked about the criteria A, what's the traumatic event. Then if we're going to look at some of the symptom clusters, the intrusive symptoms, this would include things like the involuntary intrusive memory. So, you know, you're washing your clothes and you smell bleach and it triggers a memory from when you were deployed, or you're at 4th of July parade and the fireworks go off and the sound triggers a memory. So these are memories that occur when somebody's not intentionally thinking about the trauma. We talked about recurrent distressing nightmares, also flashbacks that occur when the person kind of separates a little bit from reality and starts to feel and act as if they're back in the traumatic event. For avoidance symptoms, there's two. They need to either avoid or make an effort to avoid upsetting thoughts, feelings, and memories, or people, places, and activities that remind them of the trauma. The new category of negative alterations in cognitions and mood includes being unable to remember an important part of the trauma, persistent distorted thoughts or negative beliefs about oneself that began after the trauma, negative beliefs about the cause, consequences of the trauma, so a lot of self-blame types of things, feeling detached from others, experiencing kind of just this persistent negative emotional state. It's really common for people after a trauma, and if they have PTSD, to just feel just emotionally numb and unable to, you know, it's like I love my family, but I'm around them and I can't express it. And that's a really upsetting and distressing experience for them, especially since they're having these negative emotional experiences at such a heightened level, and then they're unable to, you know, really bring the positive ones up at all. So a lot of times people will say they just don't feel like themselves at all, and it's kind of scary. They worry that they're never going to be able to get back there. Symptoms of hyperarousal include irritability, anger outbursts, problems with sleep, you know, that can be tied to the nightmares, but they don't have to be. Being easily startled, which, you know, a car drives by and backfires and this person jumps, and markedly so in comparison to people around them. And then there was a new symptom included in the DSM-V criteria of reckless or self-destructive behavior. So the symptoms that we talked about need to have been present for at least a month in order to look at a PTSD diagnosis. They need to cause significant impairment or distress in the person's occupational functioning, academic functioning, social functioning, some area of life functioning. They can't be due to or better explained by another disorder, and obviously not a medical condition. This DSM-V included specifiers for people who have prominent dissociative symptoms with their PTSD, whether they're feeling detached from their own body or mind, or experiences in which the world seems unreal, dreamlike, or distorted to them. And then the delayed onset from DSM-IV was changed to delayed expression. So it's still that full criteria isn't met for 6 months after the termination of the stressor or traumatic event. But the phrasing, delayed expression, just better reflects the fact that we recognize that symptoms are probably there, have been there, they just haven't reached that magnitude to meet diagnostic criteria. So they're just kind of sub-threshold symptoms. But it's certainly not that the person didn't have any symptoms until 6 months after, for most people. Looking at lifetime risk, an adult in America has about just under a 9% chance of being diagnosed with PTSD at some point in their life. Every year, approximately 3.5% of adults are diagnosed with PTSD. Rates are much, much higher among veterans and first responders, depending on the specific study you look at. They can range from 25-30% all the way up to 60-80% easily. But we do know that certain traumatic events do create higher risk of PTSD. Sexual abuse victims, deployment, POW, or somebody who is the victim of some politically motivated genocide are going to have significantly higher rates than, let's compare it to somebody who experienced a car accident that was severe and they thought they may die, but the percentage of people in those types of trauma that wind up having PTSD is much, much higher. Okay. So following a traumatic event, there are multiple other diagnoses that somebody can meet criteria for other than PTSD. So as we mentioned a second ago, PTSD is diagnosed at least a month after the traumatic event has ended. So if somebody's having significant distress in the immediate aftermath that they feel is outside of the norm for what they should be experiencing, or just feel like they're overwhelmed by it, we would look at acute stress disorder. And this is diagnosed 3 days to 1 month after the traumatic event. And then we would reassess after a month to determine if it, meets criteria for PTSD. The definition of a trauma is the exact same for acute stress disorder as it is for PTSD. But the symptoms are not as rigid. You don't have to have, 1 avoidance, 2 of this category, that. So you just need 9 symptoms from any of the 5 categories. It doesn't matter if one's from this one or that. You cannot have any arousal symptoms and get the 9 from the other categories. Also, we would look at an adjustment disorder. And these are often diagnosed if somebody still doesn't meet criteria for PTSD, subthreshold PTSD, and then we would just decide whether they have depressed mood, anxiety, or disturbance in conduct, or all of those, and specify that on what type of adjustment disorder. 2 new diagnoses for this diagnostic manual are the other specified trauma and stressor-related disorder, and unspecified trauma and stressor-related disorder. And these are basically, diagnoses that are used for somebody who has a trauma, they don't meet criteria for PTSD, and specified is used if the clinician specifies why they don't meet criteria for another disorder. And then unspecified is either they don't specify for some reason or they don't have enough information in order to specify. Also, you know, after a traumatic experience, it is not uncommon for someone to be diagnosed with a depressive disorder or an anxiety disorder. In fact, looking at comorbidity, we know that people who are diagnosed with PTSD are 80% more likely to be diagnosed with some other disorder at some point in their life than those who don't. You know, it was included under anxiety disorders in DSM-IV, and like most anxiety disorders, it just has a really high rate of comorbidity. I do think it's important, though, that people not get into kind of overdiagnoses. And so if something is explained by the PTSD diagnosis, then there's not necessarily an indication to add another diagnosis. And what I mean by this is somebody who has significant, you know, nightmares as one of their PTSD symptoms, we wouldn't need to call nightmare disorder on top of that. Does that make sense? Okay. It's also very common for anyone to have a substance abuse disorder, a lot of self-medicating going on after a trauma exposure, and so that can easily develop into a clinical problem. These are a bit more common in males, as are conduct disorders. Kids often have increased separation anxiety, some acting out that may constitute oppositional defiant disorder. But again, right after, or, you know, everyone does their own thing clinically, but if I was looking at somebody, a child who had PTSD, and they were doing some acting out, I would probably hesitate to label them with oppositional defiant disorder until I'd actually treated the trauma and taken care of that. And then, you know, maybe look at later if that continued and I felt like the trauma had been resolved.
Can you speak to some degree around intermittent explosive disorder and how that could potentially be connected to PTSD?
Oh, yes, definitely. And I think I'm so glad you mentioned that, because one of the things we see with kids is they are so often misdiagnosed, and I think people just don't think PTSD for kids a lot of times, and you look at the behavior that presents itself, but children who are raised in homes with a lot of violence are often at risk for intermittent explosive disorder or other disorders. But that behavior, you know, so some people are more internalizers, some are more externalizers. So if you have a child who's acting out, it could look like that or any of the other conduct disorders or behavior problems. And then especially if it was, you know, a trauma that the whole family occurred, or if you have some family dynamics that prevent the parents from being able to kind of effectively parent, then you get into a system that just kind of snowballs, and the behavior just gets worse and worse and worse, and the child gets a lot of attention for the negative behavior, which attention is what they need, then they're going to keep acting out in negative ways. But there have been several studies that show, let's take ADHD too. Kids are often misdiagnosed with ADHD because they're going to school and they're not concentrating because they're having all of these thoughts about the trauma come back in, and they maybe are kind of, you know, bouncing around their seat because they have a little bit more anxiety. And so you look at them and they meet criteria for ADHD, but if you don't do a real thorough evaluation to kind of rule things out, you just call it ADHD, and you miss the fact that there's a trauma. And then I don't think that other thing, that be it the intermittent explosive disorder or the ADHD or whatever it is that is presenting itself, is going to get any better. So does that answer your?
That answers the question.
Perfect.
Thank you.
So looking at how do we figure out if it's PTSD? And there are two measures that are considered the gold standard for assessment. One being the clinician-administered PTSD scale for the DSM-V or the CAPS-5. It is a structured interview, has 30 items, and this can be used to make a past month diagnosis of PTSD, a lifetime diagnosis of PTSD, and also to measure PTSD symptoms over the last week. So there's actually 3 different forms of this scale, and you would use the one that was appropriate for your intention at that time. The one that monitors the PTSD symptoms over the past week is not able to be used to make diagnoses, but can be used throughout treatment in order to assure that you're actually showing some improvement in symptoms. The questions look at onset of symptoms, duration of symptoms, impact of your symptoms on your functioning, how much distress you're experiencing, and it also can look at specifications for those dissociative types that we talked about a second ago. So you can kind of get an idea of what the measure looks like by this. Oh, I went back. There we go. So sample questions. So in the past month, have you had any unwanted memories of the event while you were awake? So we're not going to count dreams in this one, and the reason being is we're going to count the dreams in another question. And then how does it happen that you start remembering the event? You want to make sure that they're not thinking about it intentionally, so we know that it is an intrusive thought. And how much do these memories bother you? And then the person's going to rate these on a severity scale of 0 to 4. Oh, whoops, sorry. Can you put them out of your mind and think about something else? Yes or no? And then about how often in the past month have you had these memories? So this is a really good measure, and especially if you're new to kind of assessing PTSD, it's a great measure to start with. You don't necessarily have to continue to use it throughout, but it really helps kind of, I think, your interview skills and diagnostic skills. And you can contact the VA and website, and you can get that measure for no charge if you're a clinician. The PTSD checklist for DSM-V is a 20-item self-report measure that assesses the symptoms of PTSD. So it can also be used to monitor symptom change during and after treatment, and it's probably a lot easier to use to monitor symptom change than the CAPS. And definitely, I don't think you could use the interview every week because it does take some time, and I think that may interfere with actually delivering treatment. The person coming to see you for PTSD can fill it out beforehand. It takes like 5 or 10 minutes, and then you can review it and compare. This is an updated version for the DSM-V, so it is not able to be compared directly to the scores for DSM-IV because there's now 20 symptoms instead of 17. So we just can't do kind of cross comparisons. It can also be used to screen somebody, for the potential, like, do you think that they may have PTSD, and kind of make a provisional diagnosis off of that. It's not valid to be used diagnostically, but definitely is a screener. Okay, so a sample item of this is, in the past month, how much have you been bothered by repeated disturbing and unwanted memories of the stressful event? And then the person responds with 0 for not at all, a little bit, moderately, quite a bit, or extremely. So 0 to 4. Okay. There are a host of other measures that are used frequently. So this list that we'll look at is definitely not all-inclusive. One of the current hurdles, though, is really finding a measure that is appropriate for the DSM-V criteria, and a lot of them are still in the process of being updated. So the SCID is a structured clinical interview for DSM-V, and it's actually a semi-structured interview. It was updated recently and will be available this summer. The other two are just self-report measures, similar to the PCL that we talked about. These are all self-report measures for kiddos as well. And the UCLA PTSD index was updated for the DSM-V for kids. The other two are the exact same that they were for DSM-IV. The clinician, the CAPS, just blanked on that, is actually being updated. Their child version is currently under the process of being updated. So we've diagnosed PTSD. Now what do? There are 4 treatments that are considered to be evidence-based, and these are, when we say evidence-based, they're level A, so those are the ones that have the most research behind them using randomized controlled trials. So that's kind of our gold standard of research. This doesn't mean that other treatments don't work. It means that other treatments don't have the research, the scientific support. And so if somebody is a provider, I would recommend, if you see a lot of trauma, in getting trained in at least 1 or 2 of these in order to kind of provide treatments that have been kind of established as being more effective. So cognitive processing therapy is a form of cognitive behavioral therapy, and it was initially developed in order to treat victims of rape, and then was later applied to kind of PTSD in general. So this treatment does include an exposure piece, and it is exposure through a written trauma narrative that is read repeatedly by the person. And then it has a cognitive piece, and there's definitely a greater emphasis on cognitive processing therapy on the cognitive piece. So we are encouraging survivors of a trauma to talk about upsetting, often incorrect thoughts that they have about the trauma, such as the world is no longer safe, I'm incompetent because I let the trauma happen. We want them to question those thoughts and replace them with more balanced and typically correct thoughts. The cognitive piece kind of focuses on themes of safety, trust, power and control, esteem, and intimacy. And there were some studies that showed that the cognitive restructuring plus exposure was superior to exposure only. So that is prolonged exposure is also a form of cognitive behavior therapy, but the idea in this is that people learn to fear feelings and thoughts and situations associated with the trauma. So by repeatedly talking about these aspects of the trauma, they can gain control over the way they react to the memories. So in prolonged exposure, a patient will talk about the traumatic event in present tense with great detail, going through the story multiple times. So they're going to talk about it over and over and over, and often in the beginning too, they'll have to really be pressed to provide more specific details. So it's not. For car accident, for example, I was, driving down the road and this car came out of nowhere and hit me. It would be more, I'm in my car, I'm listening to this song on the radio, it's a hot day, I'm going to see my friend Joe, I'm hungry, so I want to go eat. So as much of your sensory experience that happened during the trauma is what we're going to talk about during it. So what the goal is to kind of decrease the emotional, behavioral, and kind of physiological impact of the traumatic memory. Stress inoculation training is a multi-component anxiety management treatment program. Contains education, often teach people how to do muscle relaxation, breathing training, thought stopping, guided self-dialogue, And so the goal of all of this is to teach anxiety reduction techniques and coping skills to reduce the PTSD symptoms and help correct inaccurate thoughts that are related to the trauma. Okay, eye movement desensitization and reprocessing, called EMDR, was recently added as an evidence-based treatment. It is another type of cognitive behavioral therapy that's used to treat PTSD, and it attempts to change the way that the individual reacts to the traumatic memory. So it has 8 stages: history gathering, treatment planning, patient preparation, systematic assessment of trauma-related targets, desensitization and reprocessing, installation of alternate positive cognitions, a body scan for continuing discomfort or trouble spots, and closure designed to address constructive coping needs for the future use. So as you can see, it does involve some exposure. It involves focusing on a memory while the patient is receiving external stimuli, with eye movement being the most commonly used stimulus. So the person is asked to follow the therapist's fingers for 20 or 30 seconds, and they also will substitute auditory tones or tapping for the stimulus sometimes as well. So overall, scientists are not clear at all how EMDR works, but previous studies that have dismantled it have suggested strongly that it is just the exposure piece that is really effective, and they have found that this eye movement finger thing is not at all necessary for the treatment to be successful. When they take it out, there's absolutely no alteration in outcome. So outside of therapeutic interventions like psychotherapy, we also have psychopharmacology. There are 2 medications, Zoloft and Paxil, that are approved by the FDA for treatment of people with PTSD, for adults, not for kids. These are by no means the only 2 medications that are prescribed for people who have PTSD. And we definitely, we don't want to have the approach, oh, you have PTSD, you can take Paxil and you'll be fine, because the medications don't get rid of PTSD, but they are very, very useful in helping with managed symptoms at times when a person is experiencing symptoms at such a severity that they actually interfere with treatment. If somebody comes in with such heightened symptoms of PTSD, and then we're going to say, okay, now we're going to really ramp up your symptoms by going through exposure, it's really overwhelming. And so the symptoms can kind of impede our ability at times to do the treatment. And I think it also, they're a very good combined therapy. And so there's a lot of kind of future research looking at putting the 2 together in order to better treat people and maybe return them to their prior functioning quicker. So we talked about the nightmares that can be so distressing for people, and there is an alpha blocker, Prezazine, that is used to treat the trauma-related nightmares, and it can help decrease the frequency and severity that somebody experiences the nightmares. And there's some recent studies that have found that giving a morning dose of this alpha blocker can decrease kind of the symptoms that somebody's experiencing throughout the day as well. And so that's really promising research, because it, I think when you prescribe, is a little bit easier tolerated medication.
Yeah, there's a big, there's a big stigma with taking an antidepressant. And people feel like they have failed when they have to take a medicine for their emotional, psychological symptoms. So to be able to have an alternative to an antidepressant to give people is a really big deal. So.
Well, and this one also doesn't have to be taken every day, right?
Right.
Okay.
Right. And the other thing, too, along with that, with the antidepressants, they're not medicines that you can just stop suddenly, because then that could trigger even more problems with emotional stability versus this is something that is not the same type of medication. So definitely.
Yeah. So there are also some studies that have had people take a beta blocker, not this one, but before they do exposure therapy. And it helps kind of prevent as much of that physiological arousal. Because what we're knowing when we were doing brain studies is the trauma memory, is mapped, and we cannot ever extinguish that memory. What we're wanting to do is kind of override it with another more positive memory. So you can go through this trauma in this environment with me where we're where we're safe and we don't have this adverse consequence from it. But if you're still experiencing as much heightened arousal, it's much harder to get to that place. And I do think, it's hard. It's hard for people to come in and talk about, I had this happen, and you go in and you meet a therapist and you have to kind of bare your soul. And it's also hard for people to hear trauma. And some clinicians decide that they don't want to do it. That was one of the things when I've worked in a previous Air Force base. All the people were deployed. One of the clinicians had gone through prolonged exposure 2 or 3 times, training for prolonged exposure, and she was just not comfortable with it. And so all of the PTSD patients came to me. And that's fine, because I really admired her for saying, I can't do it, because I think if you aren't comfortable doing it, you can actually do more harm. And there's nothing wrong with not being comfortable doing it. There's certainly, patient populations that every clinician would rather not work with. And so if somebody does decide to go and get help, I'm looking at my time, fit is super important. It's important that you're comfortable with the clinician, that you feel like kind of you're both on the same page, and you need that, because you can't not talk about the trauma. And it's easy sometimes for a clinician to kind of enable that avoidance, because somebody comes in and you say, okay, this thing that you've been avoiding for X amount of time, I'm going to make you talk about, and I'm not only going to make you talk about it, I'm going to make you talk about it at a level that is going to terrify you to think about. And so you really have to have, I think, that trust and a good relationship. So, thank you for that information. We do know that, again, most of the time, particularly depending on the trauma, people are resilient, and they are often able to bounce back from tragedy on their own. Again, depending on the trauma, it may be more likely that they do need therapeutic intervention. If after a few months somebody's not feeling like themselves, it's probably a good time to look for treatment. Because while we want to remember that resilience and recovery are the norm, not prolonged distress, we also want to recognize that developing PTSD or another disorder is not a sign of weakness, and asking for help is not a sign of weakness. Researchers are constantly trying to learn more about PTSD. When we look at risk factors that we talked about earlier, we also want to look at protective factors. If we can make people, especially people in more vulnerable populations, a little bit more protected, then maybe we can prevent it from happening. So certainly unfortunately we can't always determine who's going to be exposed to a trauma, especially childhood traumas, but we do know, again, first responders, police officers, firemen, military members going to a deployment are going to. So as much as we can, give them the skills beforehand, then the better off they're going to be. So we want them to have a support system, have resources that they can turn to, and also approach it in a way to help encourage them to be willing to look for that assistance. People who think, okay, I can do this, and again, especially once you're in treatment, that goes to that therapeutic relationship, because if you don't trust your therapy provider, then you're not going to feel capable, most likely. So, real quickly, all right. If somebody, experiences a trauma, there are a couple of things they can do to kind of help with their well-being. One, just recognize that it's going to be a difficult time, that it takes some time to adjust and kind of allow yourself that period. And again, not only recognizing that you have support, asking for support. If you don't have support system there, finding a local support system is helpful for a lot of people. Engaging in healthy behaviors, exercising still, eating right, but then also avoiding kind of some unhealthy coping. The alcohol and drugs can be numbing, and so that short-term works, but it actually, long-term, we know that it delays active coping and moving forward, and can really interfere with symptom management. Right.
Well, thank you so much.
Thank you.
We really, really appreciate that very extensive overview of the different signs and symptoms of trauma, but also knowing about the different assessment techniques are very helpful. And to be able to wrap up with different treatment options that are available for people to consider is a really, really good thing. So we appreciate that. And I think it's important for people to be aware of the different steps that they can take to promote a healthy emotional and mental well-being. So thank you so much for that information. We're going to take just a quick 5 to 10 minute break, and we will come back and we will turn the second half of our program over to Ms. Jennifer Clark, and she's going to tell us just a little bit about resilience and her survivor story. Thank you. We hope that you will join us for the next part of our program. Thank you for joining us for the second half of our program. We want to just continue our discussion, PTSD through the eyes of an airman. We have Ms. Jennifer Clark, who is going to share with us her experiences and how resiliency has helped her through her journey through PTSD. If you joined us for the first half of our program, we had Ms. Tara to kind of share some general information with us about signs and symptoms of PTSD, different types of screening and assessment tools that are used with both children as well as adults. And she shared quite a few interventions with us as well. And so we hope that information was very helpful to you, and you will be able to glean from that as we transition into the next part of our program. So I introduce to you Ms. Jennifer Clark, and she's going to share her amazing story with you.
Well, thank you so much. It's always such a pleasure to be here and to be able to use this story to hopefully help people understand and recognize post-traumatic stress disorder and some things that are essential as far as getting through that. So, as she said, my name is Jennifer Clark. I'm a physician assistant as well as a life and wellness coach, as she had pointed out earlier. And today what I want to really do is look at a question and hopefully provide a way to answer that a little bit differently than maybe what we've thought of in the past. I want to share my own experience with post-traumatic stress with you and help you to understand and recognize it and pave a path to help as well. So the big question that I think we should look at is, why do we keep missing the mark with post-traumatic stress disorder? As Dr. Langston just did a wonderful job explaining, we've got some really incredible resources available to us in treatment and diagnosis of this, yet there are still so many people out there walking around that are undiagnosed. And I personally believe the reason for that is because there's a big stigma that's out there. And I think that stigma is a double-edged sword. I think we've got the stigma within society as far as what we perceive people with post-traumatic stress disorder to be, as well as a stigma within the people that are suffering from post-traumatic stress. And that's honestly where I feel my story can bring tremendous value, because I am somebody who was diagnosed with post-traumatic stress, and I'm certainly not the picture of somebody that you think of when you think of this condition. I am happy. I am living a wonderful, joyful life, and I've got a great career and great family, and I've overcome that. And I'm also a healthcare provider, and I've experienced things that, you never would have guessed by just, looking at me. And that's where I feel that this story that I'm about to share with you can really shed some insight and kind of help break down some of the walls that come along with that stigma. So just to kind of dive into my own experience with it, as I said, I'm a physician assistant, and I was active duty Air Force for almost 11 years. And back in 2008, I was told that I was going to be deploying. And my deployment was going to be going to Afghanistan. And at first, nobody knew what I was going to be doing. But eventually, we found out that I was going to be part of something called a female treatment team, which basically consisted of myself as a female clinician with a female medic attached to me. And we were going to be augmenting a team of Army Green Berets. And we would be traveling around doing some field medicine, as well as ultimately ending up at what we called a fire base, which was just a forward deployed location. And my role there was to basically take care of the women and children in that local area, and to provide health care to really an underserved population of patients. And I ended up at the most violent fire base in Afghanistan at the time. It actually was an old Taliban stronghold that we took over in 2002, and it was in a valley, and looking out, every single village surrounding that valley was known Taliban supporters. So it was a very interesting situation, something I certainly never thought I would ever have to experience. But in my interactions with the locals, I was also taught how to gather intelligence, which could also benefit the team that I was with on their missions. And so it was quite an interesting experience, to say the least. Like I said, I was able to really reach people that just had absolutely no medical care at all, and oftentimes they would travel on foot for days to come and see me because they had nothing else. And so that was an incredible opportunity for me as a healthcare provider to be able to reach them, but also it was overwhelming at times too, because a lot of times these people would come to me with these horribly complicated and significant conditions that in the United States we would be admitting to the hospital and taking to surgery. And I was in a minimal treatment facility where I had myself and the Special Forces medics and my medic that came with me. We had some IV medications and basics, to put casts on and a portable x-ray machine, and that was it. So I certainly didn't have the equipment that I needed to care for these people, and that was really hard at times. But, we did what we could with that. But it was definitely a challenge, especially, just not knowing what exactly was going to walk through the door each and every day. And so during that 6-month deployment, I had some moments that certainly helped me through it. There's moments that I will never forget for the rest of my life. And like the picture that you see there, I remember I was out on a field mission. We called it a MedCap, which was our basic abbreviation to explain tailgate medicine, where we just went out to a compound and we just kind of provide care for the most common medical ailments, aches and pains and nausea, vomiting and diarrhea, dehydration, and that kind of thing. And I'll never forget, as soon as I got to that compound that day, this little girl came up to me and she started just rubbing my hand. And I was kind of looking like, what is she doing? And the interpreter translated that, she was touching my hand because she didn't believe I was real. She'd never seen an American woman before. And so that day, it changed her life to be able to see somebody that she never thought she would ever see. And it was neat. She followed me around the whole rest of the day. And so that moment certainly stuck with me. And then that same day, as a thank you, the village elder wanted to give us something of value, and the most valuable thing that he could give us was a chicken. And you know, in that culture, to give somebody a chicken was a big deal, and especially me being a woman. In that society, women were really thought of as procreation only, and so their value was, you know, certainly less than the livestock for a lot of the cases. And so for him to think of me at a level where he could give me such a valuable gift was definitely a moment that I will definitely cherish for the rest of my life. But unfortunately, those moments were few and far between compared to the others that we experienced. Like I said, you know, we were at the most violent fire base in Afghanistan, and I never knew who I was treating. I never knew if I was treating somebody who was a Taliban supporter, if they were Taliban themselves, or if they were people who genuinely needed our medical care. We were getting shot at every single day. Small arm fire, mortar rounds, RPGs, all kinds of different things just getting attacked. And it was really, really overwhelming. Every single day I was exposed to some sort of trauma with the locals. You know, gunshot wounds and stab wounds, I mean, you name it, and it came through that clinic. And the picture on the slide that you're looking at now is actually the first exposure that I really had to anything traumatic in that deployment. And I was out on a routine med cap. Again, we were just going to be doing, you know, most common ailments, and we had masses and masses of people getting care, and I will never forget, I was, you know, sitting there getting through these groups of people, giving them vitamins and everything, and one of the Afghani National Police came up with this 14-year-old girl on his back, and he laid her down on my gurney, and she started demonstrating signs of brain damage. She was posturing, and she lost all control of bowel and bladder, and, you know, we certainly weren't equipped in the field to deal with that situation, but thankfully we were able to get an airway secured and get her medevaced out. And this is actually a picture of us getting her up to the helicopter. But what happened? This 14-year-old girl upset her 60-plus-year-old husband, and so he hit her over the head with a shovel and pushed her off of a roof. And so she had a significant fall and suffered really significant head trauma. And unfortunately, when she went on to the facility, they found that she had a very profound bleed in her brain, and she ended up passing away. And, you know, that was the first patient that I had ever taken care of that, you know, had passed away. So that was the first of many situations that just over time certainly weighed very heavily on my heart. And, you know, the casualties that we dealt with, you know, it wasn't just the local nationals and the disputes between them. I mean, it was with our guys as well. And, you know, we were in a place where we were in the middle of what I like to term Taliban badness, you know, and we became very close very quickly. And there's about 30 of us on this fire base. And so I grew to know and love all of the guys that were with us as brothers, and they took great care of us. And so when things happened to them, it definitely had a big impact on us. And, you know, the actual Special Forces team that we were with was comprised of 10 SF members, and by the time we were done with the deployment, that number was down to 5. And this is actually a picture of the guys that right after their vehicle hit an IED. And one of them actually, I love to tell the story of him because he was the turret gunner, which is the guy who sits on the top of the Humvee with the big 50 cal rifle. And when they hit that IED, he was thrown from that vehicle. And, you know, we medevaced him out. And when he went down to the bigger base, he kind of lied about his symptoms. He said his back hurt, and, you know, he was shooken up a little bit. And after about 3 weeks of treating him, they released him back to the fire base. And when he got there, he was the weapons maintainer on the team, and he started to notice that he couldn't do the things that he normally would do. He couldn't lift those heavy weapons like he normally could. And so he went to the team medic and kind of explained what was going on, and then the team medic came to me asking for help and explaining that he didn't want to come to me because he knew if he came to me what would happen. And so out of respect for their bond. I kind of informed the medic of how to do a neurological exam and things to look for and what have you. And so he went back and he did that and promised me if any of that stuff came back as a positive that he'd come back and tell me. And sure enough, that's what the case was. And we ended up getting him out of there that day, and come to find out, he had been walking around with a broken neck for about a month, just because he wanted to get back out there with his team. And so that was the character of the people that I was with and the dedication to service that they had, which was just certainly an incredible testimony to the types of people that we have over there fighting for our country. But as those injuries happened, sadly, I had to come to the realization that it wasn't just injuries that we had to deal with over there. And I unfortunately faced something I never, ever imagined I would have to deal with in my military career, and that's the loss of friends. First person that I knew as a friend that I lost to war was a gentleman by the name of Travis, and he was on a team, and he basically, he was actually on that trip with me where that little girl, that 14-year-old girl that I told you about earlier was treated, and he was just an incredible guy. I spent about a month with him and his team, and we were fast friends, just a really great person. He was brand new, married, 24 years old. This was his first deployment, and just a great person overall. And when I left his team, I knew that they were going to be going out on a mission that was going to really get them involved in some pretty heavy violence. And, you know, they're Green Berets, and that's what they do. And when I left them, I was so worried about what was going to happen to them. It was very early in my deployment, and I thought of them often as I knew what they were going to be getting into. And I got stuck at this kind of hub down in Afghanistan while I waited to get out to my final destination, the fire base that I was at. I was there for about a week, and while I was in transit, I ran into Travis and his team. They had had some vehicle trouble, and they were there kind of getting that situated. And I remember seeing him just kind of randomly, and as I walked up to him, I gave him a great big hug, and I told him how worried I was, and I'm so glad they're safe, and yada, yada, yada. And he just kind of gave me this look that it's forever imprinted in my brain. And he just smiled at me, and he said, Lieutenant Clark, don't worry about us. We're going to be fine. We're doing what we love. We're going to be fine. So we had some laughs, and, we said our goodbyes. And 2 days later, I arrived at my fire base, and I heard over the radio that a U.S. Special Forces member was killed in action. Later on, I found out it was Travis. And basically what happened, they stopped at a place to rest overnight, and he stepped on an anti-personnel mine and lost both his arms and from the torso down, and ended up dying in the arms of a friend of mine, a fellow PA. And he had been in the world of Special Forces for 27 years, and he told me that in his 27 years he'd never seen something so traumatic. And to hear that over the radio, a friend of mine that I had just, laughed and joked with was now gone. It was just an overwhelming sense of grief that, there really just aren't any words to describe. And sadly, that wasn't the only experience with death that I endured over there. A friend by the name of Rod impacted me even more so than the experience with Travis. Rod was another person that augmented the team that I was with at the fire base. He was a Army dog handler, and just an incredible human being, and just extreme dedication to his job and the things that he did for the team. And he was somebody that I think would have certainly been a friend for life after that situation that we were in. And he would always spend time with myself and Becky, the medic that I was with, and we'd talk about home, and he'd tell us about his wife, and he'd give us tips for things with our husbands, and it's just, a great friendship. And the morning of September 2nd, 2008 is certainly one that I could tell you is the worst day of my life. It was a morning that we knew that the guys were going to be going out on a mission, and it was what they anticipated to be the most violent mission of the season. It was, right before Ramadan started, and if anybody has ever been overseas, they understand that that's typically a time where the violence is escalated. And So they were expecting to get into some really heavy contact, but they unfortunately had no way to anticipate what was happening. And a few hours after they get out there, they ended up getting ambushed from all different directions with just hundreds and hundreds and hundreds of insurgents. And they just had them cornered to the point where they were sitting ducks. And I'll never forget hearing over the radio that we had a Special Forces member wounded in action. And as they called off the identifier, I learned that it was the guy standing in the background of this picture. His name was Joe, and basically he had been shot in the arm, and he was stable, but they were trying to figure out what they were going to do to push through to get back to the fire base or medevac in there or what have you. And they couldn't do anything. Like I said, they were just sitting ducks. And as time went on, they began to become critically low on ammo. And a couple more calls came over the radio with some of the Afghan National Army soldiers getting hit. And I can tell you, this lasted for a couple of hours. And hearing the voices of the men that I had learned to certainly know and love as my friends and brothers, that I know is calm and cool and collected, all of a sudden began to have a sense of panic and fear. It was the most profound feeling of helplessness that I think I've ever felt in my life, and there was nothing I could do but listen and pray that they could get out of there. And eventually they were able to push through to the fire base. And as they came, I remember running across the field to get to the clinic to receive what I thought was going to be 4 patients. And as they're coming through the gates, we're taking heavy contact, and the RPGs, and they're firing at us, and it's just, as you could imagine, pure and utter chaos. And they start coming through the gate, and they offload, one of the soldiers, and he's got shrapnel wounds to his face and torso and abdomen, and another is, shot in the leg, and another is shot in the abdomen, and then there's one shot in the hand, and then there's Joe, the one I was expecting, with the wound to his arm, and 2 people were shot in the face. And before I knew it, we had 13 patients in this mass casualty, and myself as the senior medical provider, and I had 2 Special Forces medics and Becky, the medic that was with me. And oh, by the way, we are a 1-hour round-trip helicopter ride to the nearest surgical facility, and they could only fit 4 patients on a helicopter at a time. So the next 4.5 to 5 hours was us, trying to maintain all of these patients and making sure that we were treating all of the things that come with trauma. And so I kind of took on the role of oversight and triage and making sure we think about all the things that come with trauma, like hypothermia, volume loss, infection, overdose of morphine, and directing, who needs to go where and what have you. And as you can imagine, it was just chaos. And in the midst of it all, I'll never forget, the team captain comes up behind me and he gives me a tap on the shoulder, and he says, "Jen, I need to tell you that we have a friendly KIA. Killed in action is what that means." And I literally felt my heart just sink into my stomach. But again, in that moment, I had no time to feel any of that emotion because I had a job to do. So I just took a deep breath and I said, okay, and I kept moving, and about an hour goes by getting the most critical patients out. And then as I'm kind of walking into the actual clinic, because at this point I was still just outside in front of it dealing with all the patients that they had offloaded, as I walked inside, I went up to him and I asked him, "Who is it?" And he told me it was Rod. And again, I can't even describe what that felt like, but I didn't have time to really process that because we had all these other patients that we had to treat. And as I worked my way into the facility, there he was, just laying on the floor, in between me and the patients on the other side of him. And there were many times during that mass casualty I actually had to step over him. I had to watch them strip him down and put him in a body bag and eventually fly out on a plane. And watching that happen to my friend, something that was certainly the most devastating thing I've ever experienced. And I later on found out what happened. Remember Joe, the person who was shot initially, they were on the same vehicle. In fact, this picture on the slide was taken a couple of days before that incident happened. And when Joe was shot, Rod was trying to protect him. And so he was leaning over him, and as soon as they started taking really heavy contact, Rod was shot in the back of the head and died instantly in the field, protecting his fellow soldier. So he certainly died a hero. And those details are just a tiny snapshot of the things that happened in that deployment. But I can tell you that 6 months of that, day after day, dealing with that, it really did start to affect me. And I began to have trouble sleeping and feeling very irritable and anxious. I started to really feel exhaustion on all counts, physically, mentally, and emotionally. I just kind of checked out for the remainder of that deployment, which thankfully that was towards the end of it. But I felt an overwhelming sense of helplessness, certainly in listening to all of the things that I heard over the radio, but not just in that, in the people that I couldn't help in the ways that I could here in the United States. And so with that came just profound guilt, having to turn people away and tell them I didn't have what they needed, or not doing what I felt could have been the best solution for people. Witnessing them, give up was just really, really difficult. So even over there, I began to avoid all of the things that made me think about that stuff, and I really just kind of checked out and disconnected from it. And I began to experience some recurring memories and flashbacks. And so that's going to kind of take us into the next portion of what I want to talk about, which is understanding and recognizing PTSD. And Dr. Langston did a wonderful job explaining that to us. And I think that this is so important for people as first responders and people that are providing medical care for first responders, because when you're able to understand why it happens after the traumas that people may witness, and being able to recognize those signs and symptoms, that's going to be how we can get to the point to get help. And so the warning signs, again, we've kind of touched on some of this stuff already, but let me just kind of reiterate. When you notice in your colleague or your patient or yourself, when you start to have these sudden and unusual changes in behavior where you're not acting like yourself, and there's all of a sudden a loss of interest in the things that you normally like to do, neglecting of responsibilities and isolation and withdrawal, and of course feelings of depression and anxiety and agitation and nightmares, all of those things are big warning signs that there is something bigger going on. And so, as Dr. Langston kind of alluded to, there's a lot of different types of symptoms that come with post-traumatic stress disorder, and these are things I want to kind of tell you on a personal level. The symptoms of intrusion, if you remember, those were the nightmares and the flashbacks, and I definitely experienced that. I'll never forget the first night I really realized I was having a flashback. It was 18 months later. I had a baby, and it was my second night bringing her home from the hospital. And I was up in the middle of the night with her, trying to feed her, and like any new parent, I was just fatigued, sleep deprived, emotionally exhausted, and overwhelmed. And as the time went on, I had trouble getting her to eat, and before I knew it, 2 hours had gone by, and I was just beyond frustrated and just spent. And her crying, her little voice started to get hoarse, and my PA mind kind of started ticking, and I started thinking about dehydration. I was like, oh my gosh, is she dehydrated? So I put my finger on her tongue, and it was dry, and so I started to really begin to panic. And I looked down at my daughter, but I didn't see my daughter. I saw a dying baby that I took care of in Afghanistan. I will never forget it. It was easily one of the worst things I think I've ever seen in my life. And it was a situation like any other clinic day. This 10-year-old boy came up to the clinic, and he had this little sack on his back, and it looked like a potato sack. And he walked in, and he just nonchalantly just plopped this thing down on the gurney and opened it up, and it was the skin and bones of this dying baby. And it was his sister, and he said, "I need you to fix my sister." And she was doing what we call agonal breathing, where the body is really on its last minutes of life and it's about to pass. And I looked at him and I basically told him that she was dying and that she needed, how long had she been like this? And he's like, "I don't know, 6 months." And I said, "How old is she?" And 6 months. And I said, "Why are you just now bringing her to me?" And he said, "Because my mom told me to." Just, stone cold, no emotion. And I told him, "She's going to die and you need to take her home to her mother." And he shrugged his shoulders and he said, "Okay." He wrapped her up, threw her over his shoulder, and walked out and didn't even look back. And it was so awful. I remember the Special Forces medic that I was with that day, it brought him to tears. It was just horrible. And so when I looked down at my baby and I saw that child, I knew it was time for me to get help, because up until that point I was in a very big state of denial, and that comes from avoidance, which is the next type of symptoms that we get, in dealing with post-traumatic stress, where any emotion that I would experience that brought me back to that, I didn't want to feel, so I went out of my way to avoid anything that reminded me of that. Movies, the news, sounds. I remember when I was, running on base, I would run by where they would fire weapons for training, and I had to change my route because every time I heard those gunshots, it brought me right back to that. So I became the queen of that, and on the surface, you couldn't tell what was going on inside. But eventually, over time, like she had mentioned earlier, my world got smaller and there was less and less opportunity to avoid the things that continued to remind me of it. And so I really did begin to experience those symptoms of hyperarousal as well. Anxiety, irritability, little things that normally would just roll off the shoulders, they got to me. Crowds of people, sounds, anything that just, could trigger me, I was much more susceptible to that. And I really did become overwhelmed with negative feelings of self-doubt and guilt, and I really disassociated from the things that I normally would do. Prior to that deployment, I was very active in the community and the base, and I was involved in the unit, and I just stopped doing all that. I would go to work, I'd do my job, and I'd come home. Oftentimes I'd just sit at the foot of the bed and I would just cry, and I didn't know how to talk to my husband about it, because there was so much of this negative emotion inside of me that I had no idea how to process. And so all of that stuff happened, and then I finally got to the point where I realized that I needed to get some help. And that's the part that I think is the biggest thing that can really, really be the message that I deliver to you today, because there's so many things that impact that. And these are some things that you can read on the slide here that really are keys that tell you that you need to get help. When those things just really interfere with what you're doing and they're no longer allowing you to really function in your normal day-to-day. When you feel that sense of worthlessness and hopelessness and thoughts about suicide, and when they're not improving and getting worse, those are all reasons why. And just this is the biggest part that I want to mention to you guys, and then we're definitely going to kind of wrap everything up. But I really want to speak to this because these are the key things that I think come along with that stigma that comes within. And these are reasons why people don't get help. These are reasons why I didn't get help right away. We think, yeah, I can handle this myself. You think, man, I've been through so much. Why can't I take this and make it go away by myself? I don't need anybody to help me. And then we think, well, you know what? I'm not that guy. I'm not that guy that can't overcome something traumatic happening in my life. Look at what I've already done. I'm not that person that everybody thinks comes back from a situation like a combat deployment, or, I'm not that person that's going to be weak and can't handle it on their own. This is a big one here. We think, all they're going to do is give me a pill. And I can tell you there's a reason why people think this, because sometimes, unfortunately, that's what happens. And we think, if I get help, that means I'm weak. And I can tell you personally, that was a big one for me, because here I am, this woman in a man's world in that special forces area, and I was automatically perceived as being weak, being a woman. The last thing I wanted to do was prove anybody right by that. So I needed to be as strong as I possibly could, and that prevented me from getting the help. This is a big one here. That's why it's in all caps. How can they possibly know how to help me? Okay? Because they didn't go through what I did. And guys, if you think about this, it's just knowing who I am and my career field. I'm a physician assistant. Who are my peers? My peers are doctors, fellow PAs, nurses, nurse practitioners, social workers, psychologists, psychiatrists. I had all of these people at my disposal on speed dial. Did I call any of them? No, I did not for a very long time, and it was because of that. How can they possibly understand what I went through? But here's the thing, and this is why I think it's so important for you to know that that's not necessarily true, because when I finally did get help, this lady sitting next to me is the person who helped me. She never set foot in Afghanistan. She'd never been active duty military. She'd never been in that situation. But she understood that, and she could help me in a way that nobody else could have helped me. And she talked earlier about that fit, and that is so key when it comes to helping somebody and finding the right match. And so don't let these things that you feel inside, if you're suffering from these symptoms, don't let this be the roadblock to you getting help. So what can we do? Think about these roadblocks within, certainly if you're somebody suffering from this, but if you're a clinician, if you're on the other side of that, what you have got to understand and embrace is you've got to break down that stigma and understand when that patient comes to you, know what it takes for that person to come to you to actually ask for help. It takes so much more courage, in my opinion, to come to somebody and say, hey, I need help, than to actually have gone through the experience itself. And so when they get to that clinician on the other side of that desk, and that clinician automatically shuts them down and just writes them a prescription and sends them on their way, that is doing so much more harm than good. And I will tell you, if you've had that experience, because I've met an awful lot of people who have, I encourage you to keep trying and to find somebody that is that perfect fit, that understands PTSD and can really help you through it. And so the last things that I really do want to mention, and I know I've got to wrap it up too, is the resilience factor, because what I had to do was go through what Tara described as exposure therapy, and it was horrible, but so helpful. And through that therapy, I have really been able to overcome the symptoms of post-traumatic stress, but there's also some things that I just want to key you into really quickly that we all have within ourselves as far as resilience is concerned. And if we know about these things, we can really use them to help us through adversity and situations in our life that can be overwhelming. And the first one is realizing that you have a choice and committing to it. And, you know, that night with my little girl, when I saw that little baby in my arms, I knew at that moment I had to decide what I was going to do next. I could let that situation consume me and define everything that I would become from that day forward, or I could do something about it. And, you know, I think in life that's where we realize that there are so many things that happen that are beyond our control. You know, our circumstances, illness, injury, loss, even other people. And sometimes we get so wrapped up in that stuff that we lose sight of the things that we can control. And so that's where we got to focus and realize that we get to choose how those things impact us. And the other part of that is realizing that you got to commit to it. And I can tell you through that exposure therapy, I did it every Friday for almost a year. Thursday nights were horrible for me because I knew this lady was going to make me relive everything in such horrible detail. I had to experience all the emotions that I was so afraid of. And I had some real struggles with that, but I finally came to the point where I had to reconnect with why I was doing it. And the alternative was staying with it and letting it become who I was from that day forward, or kind of bearing through it and getting through it, and thankfully I was able to do that. The next thing I want you to realize is that we have to have faith in the bigger purpose, and sometimes I think we get so caught up in our own agenda, in our own world, that we forget to realize that things are bigger than us. And oftentimes I think that's the majority of the time I think that's the case, but when we can really realize that there is a bigger purpose to the things that happen to us and trust in that, it really gives a tremendous sense of peace to the things that we go through. I think one of the most valuable things as far as my own resilience is this next one, which is using your experiences to serve others. Because what that does is it gives purpose to the things that you encounter. And I believe that our lives are filled with moments that define us. And oftentimes it's in those moments that we encounter people that take that extra time to share a piece of themselves with us, to inspire and empower us to become better. And when they use their own experience, when you use your experiences, your failures, your mistakes, your unfortunate circumstances, and your successes and your victories, when you use those to mold somebody else, all of a sudden it brings the most profound sense of purpose to what you go through. And that certainly has been the case with my story. Finding the lesson in life, realizing that the things that happen to us are pieces of a puzzle that all fit together, that make us who we are, and they are opportunities for us to grow and become better people. Knowing and living by who you are in your core is going to be the best compass that you have to get back to where you need to be when life kind of takes you on a roller coaster of highs and lows and maybe sends you off course. And then the last thing is really unpacking what we don't need from life's suitcase. And that means, we term the things that we carry with us throughout our lives as baggage. And when we look at what we carry with us, we realize how much negativity we carry with us unnecessarily, guilt and resentment and bad habits and toxic people. And when we're really selective with the things that we carry with us through life, and we fill that suitcase instead with things that bring us value, then we find that we are able to bounce back from adverse situations and live a very joyful and meaningful life. So that's all I have, guys. Thank you so much for your time and attention.
Thank you so much, Jennifer, for sharing your personal journey with us. We really appreciate you giving the details of your experiences and how that has impacted you, but also the different successes that have occurred as a result of that. And most importantly, thank you for your service.
Thank you.
We do appreciate that. As we begin to wrap up today's program, we would like to thank Dr. Tara Langston and Ms. Jennifer Clark for serving as our subject matter experts on post-traumatic stress disorder. We do hope that you have enjoyed our program and hope that you will join us for future webcasts. For more information on future programs, please access the Alabama Public Health Training Network listed on your screen. Thanks for joining us, and we hope you have a nice day.